Good morning, everyone. We have a really fun day planned for you all, and I'm joined by my awesome co-hosts, Hiva, Morgan, Sam's here in the chats, and we are so excited today to answer your questions about being a nurse practitioner. And before we do that, I'm going to essentially give you all just a little bit of lecture content on I passed my boards, now what? So that in case you didn't catch this last time, or maybe you are just passing your boards and just not getting interested on this topic, you kind of know the basics of what you're supposed to do and where you're supposed to go from here. So if I haven't met you, I'm Brittany. I'm a nurse practitioner with Archer Review, and all of the people that will be talking with you all will be nurse practitioners today as well. We have Heba and Morgan with me, and you can see our credentials and our interests there. And we are just so excited to talk to y'all and get a little bit more personal today. And I thank both of them and Sam for helping me out today. This is just an awesome team that we have here at Archer. So without further ado, let's go ahead and get started so that we have plenty of time for our panel. So, just a little tip here. You have passed your boards. Congratulations. Maybe you're still getting ready to take your boards, but this information will still apply to you because it's already on your mind. So, you have worked so hard so far, regardless of wherever you're at in this credentialing process. And a simple tip here for this slide is just to maintain your certifications. You already have in your possession probably an RN license, a CPR, maybe ACLS, some of these here like the certified specialty roles as an RN. And I just want to remind you that when you started school probably a year or two ago, that it's now time to renew those things. So start you a binder, get started on reviewing your things so that you are making sure that you're up to date as you're applying for these additional certifications and licenses that you are about to get. Also, just talking here briefly on role transition. These are a few facts from the AANP. I have linked the website for you down here, and you can go to this fact sheet. This is verbatim of some of the facts from the fact sheet. But we thought it would be good to give you all some statistics here. 88% of NPs are certified in primary care, and 70.3% of all NPs deliver primary care. So again, very heavy focus on primary care for nurse practitioners across the board. 96% of NPs prescribe medication, and the average scripts that go out the door are around 21 every day that we write. We hold prescriptive privileges in all 50 states and DC. And in 2021, this was when this survey was done, the median base salary for full-time was $113,000. And the majority of full-time NPs see 3 or more patients per hour. And the average age of NPs is 46 years old. So if you're younger than that and you're coming up, becoming you are a newer NP or younger NP, just that's good news because there's going to be lots of spots coming up that we're going to have to help fill. So, just some key things on your resumes. You guys are already, I'm sure, working on your resumes, probably already have a resume, but dust them off, blow them off, and look at just these tips here. I'm not going to read all of them, but essentially using keywords, because if they're putting it into some sort of screening tool or GPT, chat GPT type stuff, you want those to pick up on your words. So if like match that to your job description that you found, again, for search engines. So you're going to use things like nurse practitioner, family care, family nurse practitioner, right? You want a well-written objective at the top of really what you're after. And a good tip here is to kind of make it relevant to the position that you're applying for. You can tweak that without changing your actual values. Your most recent job is going to go first, and it's okay to use school experience. If you have any gaps for more than 3 months, common courtesy would be to explain that so they kind of know what happened. Maybe it was just, family stuff or whatever. You can put that on there for, you took a hiatus to stay home with your kids. I did for 4 years, and it's never hindered me. References, you're going to want to provide that. Spelling and grammar checks. So lots of different things that you can be doing to be beef your resume up and make it look really good so that you're going to be on the top of that stack. Licensing, we're going to go through some of these steps now of what you need to do to actually go from student to nurse practitioner working in a clinic. We need to go through that terminology and break it down as you transition. So, licensing will be the first step of your process, right? So, for example, you guys have already obtained a license when you sat for your RN boards and got that license from your state board of nursing, right? Because when anytime an individual goes through an act of obtaining permission to practice from a higher authority, that is a license. And as an FNP, you're going to be granted an additional license from your state board of nursing, have to be an RN in good standing. And this is really going to be determined by your state board Nurse Practice Act. That's going to tell you what your scope of care is. That is the nursing rule book for U.S. nurses, all the way down to LPN. So you should already be familiar with that document. If you're not already, check it out on your state board's website. And that is just going to be a really important piece of legislation. And I've even seen test questions surrounding that. So if you are getting ready to take your boards, definitely take a look at that. Not that it's going to be specific, but they're going to want to know that you know that resource of where to look. And it's going to be your state Nurses Practice Act. All right, an NPI number. You probably have never gotten this before unless you've been screening or billing insurance for some reason, if you were a dietitian or a physical therapist in a past career. But this is something that you're going to have to do now as an NP, because in order to bill insurance and CMS, they have mandated that all providers get this. And this is a unique ID number for covered health providers to help send information electronically more quickly and effectively. This was part of the Balanced Budget Act of 2004. So if you are remembering any of that from your professional role studies that you might have done, that is what has mandated the NPI. And this is going to be essentially yours forevermore. You don't have to, change this as you change jobs. This will follow you wherever you go. If you need to look up more information, you can look that up on the CMS website, Centers for Medicare and Medicaid, and find out a little bit more. And you can apply and get that number in a matter of like 10, 15 minutes. So it's pretty easy. Credentialing is going to be another part of what you have to do. So say you take that job at the clinic or the hospital or wherever you're going to be practicing. That is another process that a lot of times your employer will help you do. And it's the process. It's a very important process, because what it's going to do is allows this organization to go back to the primary source to identify information accuracy. So we all want doctors, nurses, nurse practitioners, whatever it may be, not just coming in saying who they are, right? You don't want the surgeon that's going to do a big surgery on your loved one just saying that they're a surgeon. We want to make sure that they're a surgeon. Well, the same thing for nurse practitioners, right? So they're going to go back to your boards of nursing. They're going to go back to maybe your school. They're going to go back to whoever has certified you, licensed you, and make sure that you actually are meeting the qualifications in order to perform your job function role. And insurance is going to require this. But again, credentialing is going to be probably a helpful process by your employer, but you're going to help keep and maintain and keep track of the information. So again, back to starting that binder is going to be key critical for you to have all of your ducks in a row. 3B here, I'll just mention briefly. It's not going to apply to everyone, but if you are going to be working in a state that requires a collaborative agreement, then you need to have the physician to be able to work together to provide care for patients. And many states are now allowing independent practice of NP, and that number grows every year, but many states still require a collaborative practice. Again, check out your nursing board of what is required for that. And also finding out if it's reduced or restricted authority will be important, because reduced is where some aspects of your practice may be performed independently, and restricted is where all of your scope of practice will be guided by the collaborative physician. So again, that's going to vary state to state, area, region by region. All right. Another 3B step if you want to apply for your DEA registration. Again, not everyone will get a DEA, but that's the ability to prescribe and work with these Schedule 2 through 5 drugs. That's your controlled substances. So even if you want to just prescribe gabapentin, tramadol, things like that, those are controlled medications. And many states now allow the nurse practitioner to prescribe, administer, and dispense these. So again, check with your state board of nursing as to what you're allowed. And then most people will have to go through a DEA diversion program or training, and you will go through that, and it's going to, be for your region and kind of what's going on in your area. So again, check that out. Here's the information for you that you can come back to. All right, so just looking ahead here at your healthcare delivery models, as you're looking for jobs, you need to think about what type of work you're interested in, what type of care you want to provide. So all these models are models that really are out there, and it's important to know each healthcare delivery system so that you can really go in line with your own personal care philosophy. And regardless, of which healthcare delivery model that the office or hospital or wherever you're going to be working at chooses, it's important for your office to function well as a team. And so making sure that you're asking what services are available to you, such as, do you have a care coordinator here? Is there a social worker that I can call on for those difficult cases? What about imaging or labs? Do we have other support personnel? Is there somebody working in scheduling or the front desk? And just really finding out what your job role is going to be. The other thing is the value-based care. CMS and Medicare are really, a lot of the offices now are moving to this because it focuses on patient outcomes, quality of care, and prevention strategies. Direct primary care focus on really enhanced patient-provider relationships and that flat monthly fee. And then you can also work like as an independent contractor. Fee for service is more of like that traditional care. I perform, a service, a dressing change or whatever, and then, the patient's billed. So again, just looking of what kind of lines up, what are these offices doing out here, and that what you might like to be a part of. All right, just talking about billing for just a minute. We do use ICD-10 codes. This is something that, again, is going to have to be kind of learned with on-the-job training as you go through it out. This is nothing to memorize, but this is an international statistical classification of diseases and related health problems, or ICD-10 codes. This is that medical classification list. It's kind of global, defined by the World Health Organization and used for insurance claims and processes. And it talks about incident to billing under this too. So, knowing that the physician has to be in the office, it has to be a problem that has already been started. So if they, maybe you're helping to manage blood pressure and the physician started them on blood pressure medication last month, then you could possibly potentially bill for incident two. But then if the patient starts saying something about, my ankle hurts, and you maybe order an x-ray or something, well, then that incident to billing no longer qualifies, and you'll go back to that 85% reimbursement rate for NP. So again, just take a look at that, be aware of your billing, and you do a lot of times have billing and coder specialists within your office or your healthcare system wherever you're working, and I definitely would make friends and ask them questions and get some help and use your resources there. All right, just another quick tip for you about health insurance. You will do lots of different health insurance, plans you'll service. And this is just so you're familiar with what you'll see on your screen in your patient charts. So an HMO is one of those that provides that health care for a set monthly or annual fee. They'll have fewer out-of-pocket expenses, but also a smaller network of providers. A PPO is going to be when a patient will pay more out-of-pocket fees so that they have access to a larger number of healthcare providers, not necessarily needing referrals, and they have more flexibility. And if they decide that they want to go down the road 100 miles to the largest city or whatever, they get a little bit more help there. And both of these plans are going to provide your vision, dental, medical, prescription, and hearing insurance benefits. Medicaid is going to be the low-cost health care, focusing really on people with disabilities, lower incomes, vulnerable populations. So like people like pregnant women are going to be covered under Medicaid. This is a state and federally funded program versus like the insurance is going to be more private. And then Medicare will be for adults over 65. It also is federally funded. And those with certain disabilities, like I know that end-stage renal disease dialysis is always covered under Medicare, regardless of patient age. You have Part A through D. Take a look at that. Just remember that Part A is going to be mainly your inpatient care. Part B will be your outpatient care. Part C, they can add on. It's an advantage plan and bought separately. And then D for drugs. So just take a look there. Nothing to memorize. It's just something to be familiar with as you're getting out here. You're starting to file insurance and starting to look at those patient plans of what their benefit coverage are when you're making referrals and things. All right, we'll do this and then we're going to go to our panel. So panel, get ready. Just a reminder here, your parts of your valid prescription. The superscription will be what becomes the right before the body of the prescription. It includes the patient's name, date of birth, address, current date. The inscription will be the name of each medication and the dosage amount. And then the subscription is the instruction to the pharmacist, while the signa or the sig is the part to the patient. So just a reminder here is not keeping signed blank prescriptions in your possession and to double check patient allergies prior to writing the prescription. So if you don't remember all of this, just remember this part in red and you're going to be okay just as a protection to you as the provider. All right, a topic here that's a hot topic is malpractice insurance. There are claims and occurrence-based insurances. And if insurance is made, if you do a claims-based policy, the claim made will cover you if you're insured during that time. But once it is canceled, you're no longer covered. So you would need something like a tail coverage, which is going to protect you longer. And this is the most common type of insurance from employers. And then occurrence-based policy will be providing coverage regardless of when a claim is made or a policy was canceled. So you can kind of see here on my continuum of what the options are here. You don't need tail coverage. It's more expensive because it's going to last a longer time. And again, regardless of what you do, the thing I just tell students and new nurse practitioners is regardless of what you pick, it doesn't really matter as much. Just don't ever go bare, whether your employer pays for it or you pay for it yourself or both. Just make sure that you are covered by some sort of malpractice insurance. And again, this is just talking about malpractice lawsuits, what you can do to avoid those, practicing within your scope as outlined in the Practice Act, as we talked about, maintain your stuff and stay current on your clinical knowledge. You're doing that right now. Document promptly, including objective findings, and maintain files that support your character, such as performance reviews. And now it's going to be time for our panel. So again, this was just a little bit shortened lecture for you guys. We can kind of go back over some of this as we're doing the panel, but I really wanted to allow time for everyone to be able to talk and ask questions and really be able to just spend our time together, kind of getting a little bit more personal. So, all right. Do I have Morgan, Heva? Are y'all here?
Hey, good morning, everyone.
We're here. Hi, Brittany. Hi, everyone.
Hey, all right. So, we, ask you guys for some questions, and we also have some questions that, we definitely had as new NPs, and, we just kind of want to, address those for you guys. So, we're just going to kind of go around the room and interview each other. And Sam, I know you're here. You can feel free to jump in. She's doing our chat support, but she said that she could add in too, whatever you would like to do. So we are well stocked with nurse practitioners today. So, all right, I'm going to start with a question for Morgan and Heva. You guys can ask, or I'll ask y'all the question. I'll let you both answer what you would like to say. So, for example, how many patients do you see in a day, And what are your time management strategies? So this is like a really huge one for NPs, right? So I would like both of y'all to say what you are feeling about this question.
Morgan, would you like to go first, or do you want me to go first? You want me to go? Um,
Go
so
ahead.
the first part of that question was, what's the time allotment? Is that right, Brittany?
Yeah, so like what are your time management strategies? And then also like how many patients do you see in a day? Because we just saw on that previous slide that the average NP sees 3 or more patients per hour. Now that's not always the case, right? In primary care, we're a little bit luckier to have a little bit longer time. But I know I have a friend in specialty and they have, 10-minute appointments, right? So that's the average. It's a wide variety. So really just talking about your time management and tell us a little bit about how many patients do you normally see in an hour, and how do you really, prioritize your time when you're in clinic?
Yeah, so that's pretty accurate for me too. I have 20-minute slots. It's occasionally I can turn them into 40 minutes if it's a more complicated case that I know that's coming in. Have to discuss a lot of chronic conditions with that patient. But typically it's more 20-minute slots with some admin time blocked off in the schedule. And so that can vary depending on who comes in for urgent visits, but on average, anywhere from like 12 to 16 patients a day. Time management strategies, definitely I try to be present in the appointment with the patient. So now with everything being electronic, you do have computers in the appointment with the patient, but I find that I work a lot faster by using the computer initially during my interview and then putting it aside and really trying to focus on what we're doing in that visit. It goes a lot faster that way. And then bringing it back to my desk and charting at my desk before going into the next visit. So definitely for time management, I would say try to get as much detail down in the note as you can. Try to finish the note. It doesn't have to be perfect. When I first entered clinical practice, I was really nervous about making the note perfect and did I put everything in there? And now I just focus on the key facts and make it more not detail, but problem focused, and then close it out. And if I need to go back, I'll addend it. But typically trying to get it done in the moment, I remember a lot more and it's a little bit more accurate as to what happened in the visit. So those are my tips. I'll
Those
pass
are
the
really good tips.
Yeah, that's really helpful. I love these panels because it's just kind of nice to learn. As we are in practice, it can be a little bit of an isolating thing. Because as nurses, I feel like there's a lot more camaraderie. And when you're a provider, it's pretty much can be a little bit independent. So it's nice to get together and hear about some of these things that we all do. For me, so when I first started out, I was working in community health and primary care, and I had 15-minute slots for pretty much everybody. I saw 22 to 24 patients a day. It was a lot. And a lot of times I had non-English speaking patients. Luckily, I spoke Spanish. The majority of our population did speak Spanish, but every once in a while we would have to use like an interpreter phone, which, as you know, is really hard. But I would use that time during interpretation when I couldn't understand anything being said, like if they were speaking just a totally different language, Nepalese or something. I have no idea what's happening and what's being translated. So during that time, I would catch up on some charting. So that's like one little tip that I would use. So looking at that interpretive process is like, oh, this is, this 1 minute that it takes to interpret whatever I just said, because for some reason it seems like it always takes a lot longer to explain what I said. It might be like I just ask a question and then it takes a minute to interpret that. Anyways, regardless, it's kind of a nice way to get it back. Administration time is something that you absolutely should try to negotiate. I don't think I'm a great negotiator, but that's something I would highly, highly encourage, because I think if you're working a full-time schedule, you should have at least 4 hours of admin time to be able to respond to all those things like x-ray results, lab results, emails, everything coming in. As far as time management in the room, I do chart while I'm in front of a patient. I know it's not great, but when I'm seeing such a high volume of patients, if I don't, I'll just forget completely about who it was that I just saw. So I have to at least get myself a really good backbone, and I try to have my note pretty much completed by the time I'm walking out. So I can just sign off on it. And if it's not signed when I leave the room, then I know I need to go back in and finish that. And that's kind of one thing I do. In Epic, I use Epic. So a lot of smart phrases, smart lines, and templates, I've built those things out. And so I have like my normal physical exam, and then I can go in and put in all of the abnormals and chart the abnormals, but I have the template laid out for everything as if it were normal. And I do the same exam pretty much all the time to save myself a little time at the end. So, if I'm doing a physical, I listen to the heart, lungs, look in the ears, eyes, mouth, like everything, I do it in a very, very like systematic way so that I can just go ahead and easily chart what I did do, and then what I found as an abnormal. But yeah, it's kind of crazy. Now I'm in private practice, about 16 to 20 patients a day, depending on the day, and no-show rates and stuff like that. And I would say in community health, we did have no-show rates. So it sometimes was like more like 18 to 22. But we had 24 on our schedule, and sometimes we would see all of those people.
Yeah, I
Yeah,
definitely
so
would echo what Morgan said. So try to be a good negotiator. And I see a lot of these job posts for, they estimate between 20 to 25 patients a day, and admin time's not standardized. So most places don't give you admin time. So I would just say be patient with your first job and definitely go in and advocate for yourself and set yourself up for success. Because if you're going into a situation where you're a new grad and you're seeing 24 patients a day and they're not giving you more than 15 minutes per slot, and some of these are really chronic, complicated patients, non-English speaking, all that factors in, right? And so you're going to burn out. And I know there's some statistic out there about that first year of NP practice and how many of our NP colleagues burn out and don't come back for that second year. So I don't want that to happen to you, and I want you to advocate for yourself, and you don't have to be forced to take those jobs. There are other jobs out there.
Yes.
You just have to wait for them, and don't let it taint your experience because it's such a wonderful field. So advocate for the admin time. Unfortunately, it's not standardized. So I totally agree with what Morgan said. If you're working full time, at least 4 hours of admin time. So that means 36 patient facing, 4 hours admin. That's a full 40-hour week, right? And a lot of people don't understand that. I didn't understand that as a new grad. I was like, oh, okay, I'm going to work 40 hours a week. And I started seeing 40 hours of patients a week. And by like 6 months in, I was like, this is crazy. So
It's crazy. Yeah, definitely negotiating for that time because you need it. And then also ask about ramp up. I would say having a slow ramp up as you're getting started is super important, even if you're just going to a new job. So, like when being an experienced NP now, I still want a slow ramp up because I'm learning a new system. I'm meeting patients for the first time. And so, like, I can do a quick follow up with somebody I already know about their health really easily. But if I'm meeting them for the first time, I love having more time with that patient.
It's important. Yeah. And so we have a question from the audience for you, Morgan, and it's asking, what do you do during your admin time? So what kind of things are you getting done during admin time?
Oh, yes. So during admin time, that is when I am reading all of my reports. So there's never a down moment in my day. So I am checking labs that are coming through. I'm checking we call it an inbox. I don't know, everybody's different, but it's basically where all of the results, any test that you have ordered, or any communication that you have sent out is now coming back to you. And you have to make a decision on what you're going to do. And I don't feel like school prepares you very well for lab results and how to manage those. And I used to get hung up on like a phosphorus that's off a little bit or like just stuff like that.
Well, the
So
worst is you just done
yeah,
your inbox and then you come back from from a patient room and then it's full again. And then you're just like, where did
yep,
I leave off? Where
yeah,
did I not? So getting a handle on that too is tough. Yeah.
yeah. So if you don't have admin time, like I didn't for a long time have any admin time, it's just like I work through my lunch. I'm trying to get as much stuff done during my work day. So I'm never just like, if I have a no-show, I am just like clicking through labs and trying to get things done as efficiently as possible. I use my medical assistants a lot to call for abnormals. So if it's, if there's something that I want to have a conversation about with the patient, I'm scheduling them to come back in. I'm not calling them. I used to call people, but you get stuck on the phone with a patient for 20 to 30 minutes and you don't have that time and it's not compensated. And we do have to have those boundaries. So use your MAs if they have that, or like anybody assistant to call back for abnormals and schedule an appointment if it needs to be talked about. And I just have templates to send, like, these labs are abnormal. I would love for the patient to come back in, and I always say it's nothing, emergent, but I need to have a conversation with this person. And if you have telehealth or telemedicine visit, that's a perfect way to use telehealth, is to follow up on abnormal results.
Yeah. And one thing I would say too with admin time, it's always nice to get in about at least 30 minutes before you see your first patient, because starting your day with looking at what happened to your inbox from the time you logged off the night before
Yeah.
to the morning of when you're about to walk into clinic, so that you're not putting out fires as you're seeing patients, is really lovely. So giving yourself at least that 30-minute window and being able to settle into the day, look at your schedule, see what's happening. When I was training, I remember I was training in a federally qualified healthcare center. So very similar to Morgan's situation as a provider, the providers would scrub their own schedules and know exactly what they were seeing like a week in advance. And so it does require a lot of time and dedication, but it's so worth it because it makes your day go by so much faster. And then you keep it really focused in that visit. And like Morgan said, if it's something else that needs to happen, you have them come back. But one thing I've liked outside of federally qualified healthcare centers, when you have more insurance-based direct patient care, you can really spend that time to work admin into your schedule and advocating for that, because then you have almost like little breaks in the day where you can squirrel away and get some of those labs done, get some of those charts done, play catch up a little bit, so that's not all sitting waiting for you at the end of the day when you're exhausted after seeing all those patients. So definitely working admin into your schedule is going to be helpful to you as well. And I think that's going to be in addition to the 4 hours if you're full-time, if you can really find a practice that's supportive, because it does really help you as a provider care for your patients. So that would be my other advice about admin time.
All right. It looks like we have a new question. How challenging was it to transition your mindset from RN to provider? There's a lot of, like, I would say, imposter syndrome that happens, and it still gets to me a lot. So it is a transition, and being the one that's making decisions, making the diagnosis, I think you're going to second guess a lot of your choices at the beginning, and it's probably going to keep you up at night. But that just means that you're really thinking about things that are good. You need to have some like self-care, kind of moving into this new role. But I would say, yeah, that transition of mindset is a little bit hard, and kind of taking ownership of your decisions and what you think, and trusting that it takes a while. Yeah, I think I had a preceptor who told me it was 10,000 hours before you start seeing patterns and repetitions in primary care. So 10,000 hours is about 5 years of experience if you're working full time. That's an investment. I'm just about hitting that. And so I'm not getting so I don't get freaked out about things as often as I did the first year. Definitely, I am seeing patterns in the questions and the way that you approach different things and different complaints. You do start kind of recognizing that, but the learning curve is steep. Hang in there.
And I will also
I,
say too, just to add to that, I'm sorry, Heba, I didn't mean to interrupt you.
Go
I was just going to say too, just having like a good mentor or coach. And I know we talk about this a lot at Archer, and just thinking about myself, like, I have a collaborating physician, and he's just been really good to me and always like answers my questions, doesn't get frustrated with the new kid on the block, if you will. And I had the physician prior my very first job, she was great as well. So again, kind of back to when you were thinking about what jobs you want to take and things like that, you really want to find out like who is in the office and what are their specialties, and do they like, essentially students, right? Because that's what we still are, even though we're licensed students now. And just thinking about, wanting to work with a good, whether you're collaborating or not, but just a good team, some good colleagues that you can call and ask questions and bounce ideas off of and help each other is like really important. Yeah, exactly. Don't be afraid to ask for questions and help. So that's what I was going to say for challenging to transition your mindset. Like it is a challenge for sure.
Yeah, I was going to echo that. It's a big challenge. It's a big shift in mindset because as nurses, we make our assessment, we make our recommendation to the provider, and the provider makes the call. And then so when it's you making the call, it's it's terrifying at first. And you're just like, wait, I'm allowed to do this? Like, I don't,
Yes.
I don't know if I want to do this. It's scary
Yeah.
for me to check me. And I remember that first year of practice, I was lucky enough to have mentors by default. It wasn't even how I got hired on. Actually, I asked all the questions, and the person who was supposed to be my mentor ended up not being physically there at all, even though they said they were going to be there. So I had two physicians, women, very strong women, very strong mentors who took me under their wing. And I remember I would come out and just run my whole soap note and be like, this is what I see. This is what I think. This is what I want to do. Am I missing anything? Like just total panic. And they're just like, yeah, that's great. What about this? Like, have you considered this? And it would just put my mind at ease. And so
Yes.
I always felt so much shame around that, thinking there was something wrong with it. But now that I've been so many years in clinical practice and I see new NPs, new PAs starting and feeling that shame and also being put in a spot where people are more seasoned providers that are not as good at mentoring are judging them or making them feel ashamed for asking questions. I realize that no, you know what? This is how it's supposed to be. And you really need to find a practice that is understanding of that and willing to invest in a new grad because it's really a tough transition. You are supposed to be asking the questions because if you don't, that's dangerous. And physicians
Hmm.
actually are taught that. And as a new physician, they have no shame around that when they enter practice. And so I think talking about that openly as NPs, I think is going to be really helpful for us as we're entering practice because it is exactly what we are supposed to be doing to learn how to practice. And so if anyone's making you feel otherwise, then it's not the right supportive environment for you. So making sure you are asking questions and no one's ever making you feel ashamed for asking the questions because you are being a safe clinician by doing that. You're learning something new, right? This is a new role. So I think that's really important. And then Morgan, I was going to echo on that 10,000 hours. I love that statistic. I just heard a podcast talking about that statistic, saying that the other piece of that statistic is 10,000. Within that 10,000 hours, you also have to make sure you're taking breaks, and nobody talks about that piece because I think nobody knows about that piece. So that self-care, I think, is really important, especially in those first couple of years to make sure you don't.
Hmm.
And so making sure you do have time for loved ones, yourself, family to really unplug and step away for some time to re-energize for the next day, right? That's going to be really important.
Yeah. I know. I think it like
Absolutely.
the first year there were nights it would be late at night and I'm like scrubbing my chart for the next day, which doesn't prepare you well for sleep or the next day. It's just like very anxiety provoking, kind of knowing what was coming in and setting that boundary for myself. Like I am just leaving my computer at work. And then I had my phone. I mean, this is also, I don't know if it's a great boundary, but I could check like if I had a concern about like a critical result that might be coming in, I could look at it on my phone without getting onto my computer and I could respond to that one result versus getting into my inbox and getting really overwhelmed by everything else that has come in. So it's like I can have those alerts and we had like an on-call system. So it's like there's backup and you don't have to be looking at your computer all the time. And so setting those boundaries for yourself, it's just really important so that you can survive this. Like Kiva said, don't burn yourself out. This is the long-term game.
Absolutely. Absolutely. And I think too that if it is getting to be overwhelming, like you said, taking breaks, like that's, maybe you do need to take a day off or whatever. And that's okay too, for sure,
Mhm.
when you're first getting started.
I would
So
say
Hiva,
after my first year, I went down to a 4-day work week.
mhm. Yeah, yeah. I think Hiva has the next question for us.
Oh, I do? Let me see.
Yeah. Is that okay?
Is it in the chat?
Well, no, just on our working document.
Oh, our working document. I'm sorry. Let me pull that
Oh,
up.
it's
I
okay.
didn't
It's
realize that.
okay. I
Yeah.
can ask it. It's
Okay,
okay.
you want to ask it while
Yeah,
I'm
I don't have it pulled up either.
Okay, well then I'll just ask the question. So, who wants to speak to what type of experience you recommend for someone starting out as a nurse practitioner? And do you recommend going straight to a specialty? So it's kind of a two-part question there.
I'm gonna let Hiva jump on that because I've never done specialty, so I really don't know.
made a face when you said that. I was like, oh, don't do it. Because I really think getting a solid foundation in primary care is going to serve you wherever you go. So eventually, if your goal is eventually to get into specialty, that's great, but do not close all those doors for yourself. So I didn't understand this as a new grad because 6 months into my internal medicine position was offered a position in specialty within the hospital that I was working in. And I wanted to take it because it was dermatology. And I was like, yeah, this is what I want. This is where I'm going to go. This is great. And these two women mentors talked me out of it. And they said, you really need to spend some time here and get a solid foundation in primary care before moving on to specialty. And I trusted them. So I listened. And I'm so grateful that I listened because I've gone off to do specialty work and it's not a single day goes by where I don't draw on my primary care experience as a clinician. So even in specialty, you need to be comfortable and have that solid foundation before you build on it because it will come up in your practice. And once you have entered specialty, it's really hard to stay up to date in those primary care guidelines and all that stuff to stay current. And it's like riding a bike once you go back, but you do have to kind of retrain yourself a little bit, which I found to be the case when I went back to primary care from specialty. So don't lose that skill. It's a very important skill to have. And even if your goal is to go into specialty eventually, make sure you get at least a couple years in primary care before you move on.
It's just like being a med
That's really good
surge
advice.
nurse as an RN to me. I was a med surge nurse for 10 years before I went back to NP. But everybody's like, "Oh, you stayed in med surge." Yeah, because I felt like that was just the jack of all trades, and you can hack the med surge floor, you can hack anything.
Yeah, that's
Yeah.
so
It's the
true.
I'm
same
going to
thing.
just throw one caveat in there. So, one of my really close friends, she was a cardiac nurse. She went back to school. She got her FNP, but knowing that all she wanted to do was cardiology, she had a job offer before she even started. And so that's all she's doing. She didn't do any primary care. She does electrophysiology, I don't know, some really crazy stuff in cardiology. And she's very, very happy there. And that's kind of what she set out to do. So I think if you like came from that specialty, that's exactly what you want to do. You already know that. You could probably bypass a little bit of the primary care. However, I agree with Hiva. I just find that primary care gives me so much knowledge just in my general life, and I can help family, friends. I just feel like it's like good information to have, apart from like actually taking care of people, just being just an asset to the community
Well,
as
Morgan,
well.
I don't want to call you out if you don't want to talk about this, but just think about all the different doors that have opened for you having that rich primary care background. All the things
Yeah,
you do. If you go straight into a specialty, you always have to be under a physician. We are not trained in those specialties.
true.
We do need to be under physicians in those specialties, right? And so in primary care, especially with all these states going so, independent and autonomous, there are just so many doors that open for you when you're in primary care and you have that experience. So I don't know if you want to talk about your
Yeah,
experience, but it's just, you wouldn't be able to do that if you were
yeah.
just in theology.
Yeah, so I mean, my background, so I did do, I came from the University of Washington, and out in Washington, it's really highly encouraged to do a residency program, or some places they call them fellowships, but we called it a residency. It was accredited residency program that we did. And it was great because we had a week of didactic. We got to rotate through all specialties. And it was with a primary care perspective. So we would go with cardiology, once a week or twice a week for a month. And then we would go to like rheum, endocrine, nephrology. So we got to rotate through all of those specialty outpatient clinic settings within our organization. And so you got to ask the questions, how should I work this up in the primary care before I send to you, and get that really good information. That in that residency program was awesome. And then there was a didactic. So that is an option for people out there. I'm really glad I chose to do that. Yes, I did take a big pay cut that first year, but I feel like it really prepared me for what I was going to do on an independent place. And then moving from that, I did do community health and then transition to private practice. And since then, I have decided to try to open my own clinic. Right now, it's telehealth only, and I'm figuring out telehealth and mobile health. So I go to patients' homes. But yeah, I think that background has given me the opportunity, the knowledge, and some of the confidence, even though it's a wavering confidence, on trying to do something on my own. And I work in Colorado, so that is an independent practice state. So that's a little caveat there. I know that it's hard to work in certain states. You have to have that collaborative agreement. However, you can still own your own practice in a collaborative agreement type state. So there's ways around that. You just have to, if you're ever interested in that, I would love to talk more about it. I am by no means an expert yet. This is like 4 months in the making. So
We're going to get her to do a talk on this. Don't worry.
yeah, I said we need it to be successful first, but
you already are successful.
You are, Morgan. You're doing great. And so you can have your own practice, private practice. Like I'm in Texas and you still have to have a collaborating physician. But a lot of my colleagues who have their own practice, they just hire a collaborative physician, and it's someone that you have to negotiate how much you're going to pay them, how often they're going to review your chart. So it's that in that sense.
yeah.
You can still do it in states that require the collaborative practice.
Yeah, there's a lot. And okay, sorry, one more thing just came up. July asked about not finding work. So I'm going to speak to Colorado. It's a saturated market right now. And I feel like just pay wise, I'm going to say because it's kind of saturated, I have noticed that the pay moving from Washington to Colorado, even though the cost of living is very, very similar, the pay out here does seem to be less. Didn't quite realize that when we decided to move. However, there's jobs. There are jobs and you can get a job. But I have a couple of friends that do work as RNs part-time just to make a decent salary.
Mm-hmm.
Yes, exactly. Need to, Sam put in the chats for y'all, need to know where to look and all about networking. So it took me about 3 or 4 months to get my first job out of school. I kind of used that time to just kind of breathe. My grandmother passed during that time. So, it actually ended up working out for us. And then after I got that job, it seems like once you get your foot in the door, then I got a phone call about my current job. So, same type of thing. It's just kind of, if you do a good job at one, then, your name gets around or whatever it be. And, you will have offers. Like I've never had a problem. And even though I am in a saturated market, I personally have really never had a problem with finding work or getting jobs. And, and I won't say this, I will say this too. I haven't gotten every position I've ever interviewed for, right? But it's about those right jobs. And, when one door closes, something's going to come open. So don't get discouraged about that.
Yeah, and I would say we just hired a new nurse practitioner who was, I think he had graduated couple years ago and he worked as an RN. I would strongly, strongly encourage you not to just jump right back into RN work because it's hard to get a job if that's what you just go straight back into. I would say trying to figure out how to differentiate yourself, getting certifications, different things. If you're having trouble finding a job, don't give up and don't just like fall back into your RN, your old role. Because I think the further out from school you get, the harder it is to start practice. Consider some of those residency fellowship programs, different opportunities. Try to make yourself look different in the competitive job market. But I think it's the new grad job market, I think probably is a little bit tough. But hang in there and see what kind of additional education or opportunities or volunteering stuff that you can do to set yourself apart.
I was just going to say one really nice way to network in your community is going to local events. So if you sign up for the local nurse practitioner community and go to the events, usually the people leading those events are pretty high up in a lot of different clinics in the area. And so you can always introduce yourself, bring a copy of your resume and tell them your interest and get your name out there that way too. I see that a lot with our meetings here in Dallas. So that's a nice way to get your name out there. But I would say, I would echo what Brittany and Morgan said. There's always work. You want to make sure you find the right work for you, right? And that's good advice about jumping into the RN. I've seen it both ways. I've not seen anyone stick out their RN job for 2 years after graduating. I think that would be really hard to jump in, but I've also seen RNs stay in their job until they find the right NP job, and that takes anywhere from 3 to 6 months. So you have to make ends meet financially, right? So that makes sense. Yeah.
So we got another question coming in about fellowship. So Morgan, you talked about fellowship, and of course we all do clinicals while we're going to school. That's mandated. And so I think somebody July is wanting to know a little bit more about your fellowship, and even there's fellowships and then there's also like residencies. So does anybody want to speak to that a little bit and tell us a little bit more about that?
I mean, I think the benefit here is, so we did independent practice. So some days we were completely on our own, which really gets you prepared for what you're going to be doing when you're no longer a resident or a fellow. But then we would have, most of the time, we would have a designated preceptor. So everybody talks about making sure you have good mentorship. So if you are interviewing at a place and somebody is going to be kind of a designated person, even though Hiva's kind of fell through, she had 2 really good mentors to help her answer questions, and she had somebody to go to. During a residency or fellowship, you might have like 4 other residents work. So in my case, there were a total of 5 of us. And we all worked kind of rotating different days, and we were in different, clinic rotations all the time. But then we would come together once a week so we could ask lots of questions amongst ourselves. So there was a lot of collaboration amongst residents. And then also we had a preceptor with us at all times. We had physician preceptors, we had nurse practitioner preceptors or PAs, and you get a huge, huge perspective from those different kind of backgrounds and the way that people are trained differently. And so I 100% think that it's a really, I'm glad I did it for myself. I know it's not an opportunity that everybody can have, but I definitely, if it's an opportunity, something you're thinking about and you're going back and forth and finances aren't a huge deal, like it was a bit of a pay cut compared to, like I had a friend that went straight into practice and she made a lot more than I did being a resident, but I'm glad I did it.
Okay, so here's another question that I have for you guys, is talking about what type of experience do you recommend for someone who is becoming an NP? What is the single most thing that you feel like prepared you the best for, what you're currently doing now? What path have you taken to get to where you are today?
I would say get as much exposure in all age ranges as you can. So I was lucky to be a pediatric nurse in an outpatient setting where I saw all the ages. I had my own schedule, so I got used to pacing myself that way and practicing somewhat autonomously that way. But when I was in my first internal medicine role, I drew from my clinical experiences a lot. And so getting as much breadth in those clinical experiences, so training at a federally qualified healthcare center where I saw everything and we were managing everything was really good experience because I was managing pediatrics, OB, geriatrics, chronic conditions, urgent care, acute conditions. So trying to make sure if you're in a program where you're setting up your own clinical preceptorships, you want to get as much exposure and breadth as possible because you'll be drawing from that in your clinical practice when you enter clinical practice.
And I will say this too, talking about because we set up our own clinicals, HEVA as well. And regardless if you have or haven't, you can find those opportunities out there in the community. Like I know our hospital has the shadowing observer program where you can go and just spend some shifts wherever you want to go, and they'll help you set that up. So look for even other opportunities. But I was really nervous about managing like anxiety and depression and starting an SSRI in primary care. And so my last semester, I spent 2 weeks just on my own time with a psych NP. And I'm like, look, I'm not looking to do this, but I just want to feel comfortable prescribing these medications before they get to you. And so I did that, and it was like a really good experience. So definitely would agree of try to get as much experience as you want or like as you can in a variety of not only ages, which is good, but also areas for sure.
Yeah.
All right.
Yeah,
Morgan, did you want to add something to that?
I think you guys hit it. I mean, I don't have much more to add.
All right. So, this question is for Heva. We've touched on it just a little bit, but can you give any insight to contract negotiations?
Ooh, that's a tricky one. So I would say first and foremost, ask for what you want. You can be pleasantly surprised. Worst case, they say no, right? I always say that to my daughter. What's the worst case? They say no. So ask for what you want. And then if they say no, I've learned this from my friends who are not in the medical field, who have worked in HR in corporate America, that you can always pivot and ask for it in a different way. So if it's a salary that they can't meet, can they make up for it in more continuing education stipend? Can they make up for it in more vacation days? Can they make up for it in other ways, maybe a sign-on bonus? And that way you're making a commitment to them and they can also make a commitment financially to you, right? So trying to get creative with negotiations and not being afraid to ask for what you want, because
Mhm.
you could be really pleasantly surprised. So make sure you know what you need going in and get creative with it.
Yep. I have a friend,
Absolutely.
I just talked to her on Friday, and they gave her initial salary offer, and then she came back to him and was just like, hey, like a really nice email reply. You can use a little chat GPT if you need to help draft that email, which is always a good way to get that kind of draft going. Um, and then just ask for what you want. And in her case, they actually came back and offered her more than what she was asking for. And I'm not going to say that always happens, but they recognized her value that she was going to be bringing to with the training and the experience that she had. And they were able to make it work and figure it out. So do not accept the first offer. And like Hiva said, there's other ways to negotiate and other benefits that they can offer. Um, CEs and time off for continuing ed, I think, is a huge overlooked thing, because there are conferences that are awesome and you want to be able to go, but you don't want to have to take your vacation days to go to those. So ask for those days to be paid.
Great point.
Absolutely. Well, I think this about wraps up our time together. If we have any other questions, you guys can email them to our email address that we have listed here for you on the screen. And I think we'll probably end up doing this again because I've had a really great time. Just going to end the chat today with the mentoring QR code that you guys know that I love to put up for you. We're here for you if you need us and want to deep dive a little bit more. We don't promise to be experts on everything, but we do promise to be your best cheerleaders. So, whatever we can do to assist you or help you if you're getting ready to take your boards, we still have the other things available to you. So, use that QR code there, see what we have coming up for these exciting things this fall. And I think both of you all, Morgan and Hiva, for being so transparent today on the phone call. I really appreciate it. And Sam in the chats, you left a lot of really good information and links for everybody. So y'all check that out, what Sam left for you all, and y'all should be feeling really good and prepared about now. So. Well, I hope y'all have a great rest of the week. We'll catch you coming up. I think Morgan, you have something tomorrow, right?
Yes,
And
substance use disorder. So join
yeah,
me.
so we are around, and you can hit us at that email as well. So y'all take care. Have a great rest of your day, and we'll see you soon.